To start off the Pmf lecture, I'm going to show a few videos. There's nothing to write down in your outlines that go along with these videos, but I wanted to show some examples of what Pmf looks like in a clinical practice. So the first one is about 3 minutes long. We'll just show the generals, reviewing of the patterns of Pmf. In class, we already went over these in standing, learning the patterns. As I watched this, I didn't realize that they use some of the same word pictures to explain the Pmf patterns, like the ballet and the dog thing. So I guess that must click for a lot of people. So we'll watch this one first.
D1 flexion. All right. Grab my fingers, or I'll do flex fingers, flex wrist, radially deviate, flex your elbow as you come up and across. We're doing external rotation of the shoulder, adduction, flexion of the shoulder, and anterior elevation of the scapula. I'll do finger extension, wrist extension, ulnar deviation, pronation, internal rotation, abduction, extension, and posterior depression of the scapula. Ready? Okay. D2 flexion. Finger extension, wrist extension, radial deviation. We got elbow extension, shoulder abduction, and external rotation, and supination. That's it. Flexion of the shoulder. Finger flexion, wrist flexion, ulnar deviation, pronation, elbow flexion. We already have shoulder extension, internal rotation, and adduction, and scapular anterior depression.
Alright, now we're performing toe extension, ankle inversion, ankle dorsiflexion, knee flexion, hip flexion, AD deduction, external rotation, and pelvis anterior elevation. D1 extension, toe flexion, ankle plantar flexion, ankle inversion, knee extension, hip abduction, internal rotation, pelvis posterior depression. D2 flexion, toe extension, ankle dorsiflexion, ankle eversion, knee flexion, hip abduction and internal rotation, pelvis posterior elevation. We'll do D2 extension, toe flexion, ankle plantar flexion, ankle inversion, knee extension, hip adduction, hip external rotation, and pelvis anterior depression.
All right, the next one is just showing what some of the Pmf patterns could be done with a TheraBand. I'll just show a little bit of this. So this would be for exercise prescription for somebody to do home exercises for Pmf.
Call it Pmf for short. And it's a diagonal pattern that really elicits all the muscles in the shoulder that are important to get strong. So what you want to do is, I have Jessica standing on the band with her left foot, and she's holding the band with her right hand, with her thumb pointing down at her left hip. Now what you want to do, from this position, you want to move your arm in a sweeping diagonal motion. That's right. And notice your thumb should be pointing down toward your hip, and as you're coming up, it rotates to the thumb up position. Perfect. And it stays in that nice diagonal pattern. This is a diagonal pattern exercise where you start with the involved hand holding the TheraBand at your uninvolved shoulder, and then as you sweep down, your thumb is turning so that it's away from your body. Good. Now you can either do this exercise with the band in the top of a doorway, or you can hold on to it with your opposite hand as Jessica is demonstrating. Good. And remember, the thumb goes toward the shoulder and then away from your body. So you're getting that rotation component. Good.
This next one is a little different, but it's pretty interesting. They talk about what exercises you can do if you're working with a stroke patient.
Pmf, proprioceptive neuromuscular facilitation.
Pn, not Pn.
Yeah, not Pn, P, the letter N.
N. Paul, Nancy,
Yeah.
Frank, PNF.
There you go.
Mm-hmm.
All right, so we're going to start in both times, you're going to start with the palm down. Now, this is your involved side. This means that there's no strength there. So you're going to take it, you can grasp your fingers like this, you can grasp like this, either way.
Mm-hmm.
But I'm going to take it palm down, so the palm is down, and you're going to take it and you're going to watch with your eyes, because this helps create some of the recovery.
Right.
You know.
Visually, oftentimes you
Yeah.
neglect one side as well with a stroke.
Right.
If you know someone with a stroke or you had one, you know exactly what we're talking
Right.
about.
So the palm is down, and this left arm is helping the right arm take it up here. And now I go to the palm up position.
Right.
Okay? Now what you're trying to do is you're trying to have this arm help as much as you can. This one.
Right.
And you're trying to think about it getting to help. And this works on posture, and it's also getting some rotation of the body, and things that you all need to do to have it happen after you've had a stroke. So palm up, palm down, palm up. Palm down, palm up. Okay? Now you can also start in this position.
Sure.
Again, palm down, but you're in the upper position now. Palm down, palm up. Palm down, palm up.
Now this is, to me, a little confusing because I keep forgetting which is the involved side. We should have put a tape around your arm, but so this is the side that's
This
weak.
is the side that's weak.
If you had a stroke and I had this arm like this and I let go, this is what would happen. It would probably just flap down.
Exactly.
And then you're a candidate for this type of exercise, or even if you have a little strength in it.
All right, just to review these again. I'm going this way, or I'm going this way.
So if you look at just the hand that would be weak, can you do that motion?
Okay.
Once it gets better,
Yeah.
So that would be the side that doesn't have the strength to do it. But just so you see, the palm is towards and now the palm's down.
And here. Okay.
Mm-hmm. Excellent.
All right. If you're 40, 50, and over, you're going to want to subscribe.
Here is a patient that is paraplegic from a spinal cord injury, and he is doing some modified PNF exercises. This is an interesting and unique way to incorporate PNF.
Stand it down. All right, good. Here we go. In press. Stand it out. 6. Good. In press. Stand, extend. Bring that foot across. 7. Press. Keep those arms underneath you wide. Good. Press. 9. Keep those arms up. 10. Good. 5 more. Here we go. Press. There you go. Good. Push. 11. Drag it down. Push, push, push. 12.
And then the last one is another example. We have another spinal cord injury patient. She's doing some PNF in a standing position. Okay, so what I'd like to do now is continue on to the notes. And I don't really have a presentation, a slideshow presentation, but we'll go through the notes here. Whoops. Let's shut all these off. Okay. So the slideshow, I don't have one, but we'll go through the notes and talk about what is PNF now that you've seen some examples of it. So we have a combined movement pattern that uses neural stimulation to stimulate or facilitate or inhibit a proper muscle response. So we're trying to get a muscle to contract, either contract at all or a greater, stronger contraction. This technique uses proprioceptive, cutaneous, and auditory input to produce functional improvement in motor output. So if we think about that, we're going to be using proprioceptive, so we're going to be talking about muscle spindles. We'll be using cutaneous input, so it's important where we have hand placement on PNF for the resistance, and auditory, so we'll be using words like push, pull, or fast, go, slow, hold, things like that. It's based on the principle that voluntary motion of one muscle can be facilitated by the action of another, and the principle of reciprocal innervation takes place. So the agonist contracts, causing the antagonist to relax. All right. Neurophysiologically, what do we have going on? An impulse to a muscle or from muscle causes what's called an impulse volley, which is a discharge of a limited number of specific motor neurons as well as the discharge of some surrounding motor neurons. So we might be wanting to cause an impulse to the quadriceps, let's say. When that takes place, we have a limited number of motor neurons of the quads that will discharge, but also some of the surrounding motor neurons, so some from the adductors or maybe the abductors. That's what they mean by the fringe area, are also going to discharge. An impulse can cause recruitment and discharges of more motor neurons, and it's called then facilitatory. So if we have more motor neurons, it's facilitatory. We want that for strengthening. An impulse that causes motor neurons to drop out of the fringe area is inhibitory, and it's used for stretching. So we're going to use PNF for strengthening, and we're going to use it for stretching, depending on what our goal is. The motor neurons of the spinal cord always receive a combination of inhibitory and excitatory impulses from the afferent nerves. Whether these motor neurons will be excited or inhibited depend upon the ratio of the two incoming impulses. All right. Just to review on a couple terms, autogenic inhibition is a low, slow stretch is hold, and the GTOs cause a reflexive relaxation. That's autogenic inhibition. And reciprocal inhibition is when the agonist contracts and the antagonist relaxes. So we'll be referring to those two terms when we talk about different PNF techniques. So just a reminder of what those are. All right, the next section is facilitation of various afferent receptors. We'll do a little exercise in class as when we review this for an example. But the concept here is that the brain recognizes only gross joint movements and not individual muscle actions. So our brain will recognize if we turn and look to our left as a movement pattern, but it doesn't really recognize if you want to say, I just want to contract my right internal oblique. the brain doesn't function like that. It's going to do gross motor movements. So strength of a muscle is directly proportional to the number of activated motor units. So motor unit, remember, is the muscle and the nerve system that attaches to the muscle. Strength can also be improved when stronger muscle groups help the weaker groups. So that's why we like this overflow or fringe area concept that we talked about earlier. The discharge of motor neurons can be facilitated by peripheral stimulation, resulting in increased muscle tone or strength of a voluntary contraction. That's a reiteration of what we were talking about. The following will serve to facilitate or increase muscle strength when we're using PNF. So these are 4 things that we want to incorporate as we do PNF. Number 1, tactile input. So we're going to have hands on the arm or the leg or the foot to help increase or facilitate movement. And we want to touch the areas that we're trying to get movement. So if we want more dorsiflexion and inversion, we're going to put our hand on the inside top of the foot to facilitate movement towards there. So if we want more input out of the hamstrings, then we'll put our hand on the hamstrings. Number 2, auditory input or verbal cues. Words like push, pull, hold, relax will be used. Number 3 is oculomotor input. It's important that the patient watches the body part that's being moved. They talked about that in one of the videos. And then proprioceptive input. Sometimes we'll use a quick stretch to facilitate movement by firing the GTOs to get a greater response. I just put this quote in the bottom of your notes. I think it helps talk about patterns of movement, these diagonals that we've been talking about. But it says the optimal line of movement produced by the optimal or maximal contraction of the major muscle components from their lengthened state to their shortened state. The normal subject readily demonstrates greater strength when they perform in the diagonal pattern than when the line of movement is to either side of the diagonal. So lots of studies went into figuring out where we have the greatest strength. So having the arm move in all sorts of different patterns and movements and diagonals, they found that the D1 and D2 diagonals were those diagonals in which subjects usually had greater strength. And we'll see that a lot in even sports. Athletes tend to use diagonal patterns. They're kicking and throwing, and we don't kick in a cardinal plane or throw in a cardinal plane. Voss, Ianta, and Myers are 2 of the leading researchers and PTs in PNF. If you go on to PT school, you'll study them a lot. A few more notes in here. The central nervous system stimulation produces mass motor patterns, not straight line movements. So not straight line movements. And these mass movement patterns incorporate diagonal motion in combination with rotational movement. So all the movement patterns, the D1 going from flexion to extension, or D2 flexion to extension, or vice versa, will have these 3 components. They'll have A, flexion or extension, so the shoulder will go into flexion or extension, or the hip. B is adduction or abduction, and C is rotation. So when we did our shoulder patterns, the shoulder always went into either flexion or extension, adduction or abduction, and a rotation, those 3 components, and same with the hip. And then finally, we have principles of application. So things that we'll think about when we do our PNF patterns in lab. Number 1, the sports rehab specialist hand placement is important in providing appropriate facilitation of the deep touch and pressure receptors. So we want to be firm and reassuring, not a light touch that's just awkward and uncomfortable. Number 2, verbal cues are given. Number 3, the technique should not be painful. Number 4, proper instruction in PNF patterns before the start of the exercise is important if the muscles are able to optimally facilitate. Number 5, rotation is an important component of the diagonal motion. It begins distally and progresses towards the proximal muscle group as the patient continues through the motion. So when we do that D1 upper extremity pattern and you start in pronation, and your arm is going to move into supination with external rotation, we start distally. So before you get halfway through the pattern, that arm should be fully supinated, but you'll still be moving into shoulder external rotation. So distal rotation prior to the proximal rotation. Without a rotational movement, it's important to facilitate a maximal contraction. So the distal rotational movement should be completed no later than halfway through the diagonal pattern. Number 6, providing traction is sometimes used to separate the joint surfaces, or approximation to compress the joint surfaces, and that will help to sometimes stimulate proprioceptive nerve endings. Number 7, a quick stretch may be applied immediately before beginning the movement pattern in order to get the stretch reflex facilitated into a stronger initial response. It's most effective if all the components of a movement are stretched simultaneously. I'm going to stop here now. If you've been listening this long, you're doing a great job. On the front of your notes, I want you to draw a picture of, let's say, in front of this outline, draw a picture of 3 flowers. 3 flowers, and then I'll know that you got this far in your outline when you show it to me on Thursday, if you have 3 flowers written up there. All right, moving on. Number 8, the motions are performed precisely through a smooth range of motion, therefore resistance may need to be varied. I'm talking about manual resistance. Number 9, the sports rehab specialist must use good body mechanics, stand in the direction of the line of movement, bend knees, and be close to the patient. We'll practice this in lab. Pmf can be used in lower extremity and upper extremity. We learn those patterns. It can also be used for trunk and neck. We will not learn those patterns. That's used for more neurologically involved patients. In application, the athlete moves through a diagonal pattern you choose, and you provide manual resistance to improve strength, flexibility, coordination, and control. It can also be used to manual resistance free weights or TheraBands, and you saw a little bit of that as well. So that ends this lecture, and we will see you on Thursday.